Whether in the urban sector or rural sector, women and girls bear a disproportionate burden of global health inequities. Social upheavals and natural disasters and public health emergencies, such as disease epidemics, exacerbate and amplify these health inequities. COVID-19 bears this flag. So today, I would like to take this opportunity to briefly focus in on this, especially in the last decade of realizing the SDG goals, and as we process through the current pandemic. So the landscape. The SDG framework, as most of us we're well aware of, the Sustainable Development Goals with the 2030 agenda. This framework presents a broad approach with a strong focus on equity and leaving no one behind. All of the goals impact the lives of women and girls, but 4 zero in specifically. Goal 3, on good health and well-being. Goal 5, focusing specifically on gender equity. Goal 8, decent work and economic growth. Goal 10, reducing inequalities. These serve as action points for focusing on the health of women and girls as an economic value for the robust development of communities and municipalities and cities. It's interesting that now I'm a medical sociologist, social epidemiologist, and in this time, we are forced to collaborate, work as science teams with economists and planners and everyone else to think critically of how health impacts our future and our development. So when we think of valuing the health of women and girls, increasing the investment in the health of women and girls produces stable and productive communities. It's cost efficient. And as we well know, in many countries, every dollar spent on family planning saves at least $4 that would have been spent treating complications arising from things such as unplanned pregnancies and other concomitant issues. So COVID-19 has brought this flag and brought us squarely to be thinking of the existing inequities. So experience from other shocks such as Ebola, HIV/AIDS, SARS, MERS, show us and have exemplified this deepening of pre-existing inequalities. And they also amplify the vulnerabilities in health, social, political, and economic systems. So the UN report, UN just released a report back in April on the impact of COVID-19 on women and girls. And according to the United Nations, the world's formal economies and the maintenance of daily life are built on invisible and unpaid labor of women and girls. Where does this occur? Women and girls care children and families, older family members, ill family members. They're involved in the informal sectors, service industries. And so women are doing 3 times as much unpaid care work as men. And data shows that women predominate in the informal sector and in the service sector, which has been dramatically impacted by the current pandemic. If we take for the US, for example, women hold 78% of all hospital jobs, 51% of pharmacy jobs, 51% of grocery store roles, bringing them to the front line. They comprise 70% of the global health workforce. And unfortunately, I must note that they earn roughly 33% less than men. But focusing on the health and the current issue as frontline responders, women are health professionals, representing, as I said, 70% of the global workforce. In addition to doing that, being out, they're also caregivers in homes and families. So when they go home from work, they are at the front line. And if family members are ill, if they're elderly, or even going out into the care sector, not for family members, but working as caregivers in home situations. Women are more likely to be community volunteers. So women are making critical contributions to address the outbreak every day and to mitigate the impact. So we're seeing, and this is a natural experiment evolving as we see data being collected, women are bearing a disproportionate share of the adverse health, social, and economic impacts. So how does this look? If you think about it, in spite of their participation, women are 25% more likely than men to live in poverty. That means they lack resources to provide for their and their children's health. This graphic from the United Nations visibly shows this impact. So, and in addition to that, they're more exposed because they're frontline. So if we look at the case of 2 European countries, Spain, we see that female healthcare workers were greatly, compared to men, were much more infected because they're much more on the front line. The same is the case of Italy. And this is in the formal healthcare sector. It doesn't reflect the informal. So women, to recap, women bear primary and secondary impacts. And this leads to, I'll highlight 2 particular issues of access to care and poverty. So what do we do? What hope do we have for mitigating these impacts? Public health preparedness and response should consider both the direct and indirect health impacts on women. And the United Nations recommends that there should be adequate representation of women in response and recovery planning and implementation, not just focusing on the outcomes at the beginning and at the end of the equation. An earlier presentation focused on public health messaging. Such messaging should target women and girls specifically, and not globally, and not just men in particular. We should also address the specific needs of women as frontline workers, particularly health and psychosocial and work environment issues. We should provide resources and standard health services for women at all stages of the life course. So girls, women, elderly women is of primary importance. So in this last decade, and with the experience of COVID-19, we must work to achieve Goal 3, the good health and well-being, Goal 5, gender equity, Goal 8, decent work and economic growth, Goal 10, reducing inequalities, but recognize that each goal impacts our response to COVID-19. And this graphic from the United Nations very nicely shows how each of the goals, the SDG goals, are impacted by, in this instance, COVID-19 pandemic. But we know that we have coming and emergent pandemics and health emergencies and health inequities that plague the lives of women and girls. So this call to action really focuses in on addressing these gender inequities, and we must address them. And if we do, we can realize this triple gender dividend that would benefit everyone. Addressing the gender inequities that exist in health will yield to health for all. It would bring quality and accessibility to health to more people. In terms of gender, recognizing and rewarding and facilitating the integral role of women in the care economy as health professionals and unpaid care provided by women and girls in households, and the underpaid services provided by women in the informal sectors. In terms of the economics, it would bring more jobs and increase productivity. And increased productivity makes communities more viable, they're more economically effective and healthier. So it's important that we see the health of women and girls as critical to the health and economic viability of communities, municipalities, and cities. So with that, I want to thank you. And this was an intent to focus in on these salient issues and to raise awareness and to encourage, as we think of research and not just for the sake of gender equity, but looking at this from the whole perspective of the life course, girls to women, and women and their disproportionate role of providing care in both the formal and informal sectors, and making sure that we are responsive to the health needs and the economic needs. Because as we all know, and as we've learned from historically, once women are healthy, the family is healthy and the community is healthy. So this was a call of attention to this issue of gender equity and health in the current pandemic, and calling us to be aware that as we focus in on coming emergencies, thinking of a whole population approach and specifically zeroing in on the health of women and girls. Thank you.
Thank you very much for that talk and for ending the European Public Health Week on that note. We do have a few questions for you before we do come to a complete end. So we have heard a lot about people appreciating the health workforce at the moment and demands for them to be better looked after when the pandemic is over. As you mentioned, 70% of the global health workforce are women. Do you feel this appreciation could spread into other industries post-COVID?
So I'm focused on, I'm a medical sociologist, social epidemiologist, so obviously I focus on the health, but definitely, and that's why I said if women are healthy, and using, and men too, but I'm focusing on women at this point, if women and girls are healthy, the community is healthy, and the population is healthy. So we know that in terms of entrepreneurship and business, we rely on a healthy workforce. And so definitely it impacts our ability to produce cars, our ability to work in, work on farms, or to be economically viable. So every aspect of the workforce has implications for the health of communities and societies.
Thank you very much. You also mentioned providing resources at all stages of the life course. Do you notice differences for women that are different from general differences across the life course? And if so, can you explain what those differences may be?
So life course in terms of development would be for women and girls and women would be different from for boys. So life course in term, women are the reproductive arm of human beings. So women and girls have issues related to fertility development, reproductive development, access to sanitary and appropriate care. Women bear children, so maternal and child health issues. Girls become women. Girls need to have clean water access, good sanitation in order to take care of their reproductive selves. And because women are the fulcrum of the family in terms of care, bearing children, largely providing for the care of children and for ensuring that the home is equitable. As women are professional women, are in the workforce, but nonetheless, women are still seen as the bearers of care. We have had progress where there's equity in terms of men and women in homes, but generally and globally, especially in the global South, even in the global North, it still falls back on women. So in terms of reproductive health, in terms of change over the life course, stress and development, it impacts not just the woman, it impacts children and the family. In terms of care of or elderly parents and relatives. And as women age, women go into post-reproductive life, the needs vary in terms of their health care. So the impact not just on infectious diseases, but in chronic disease care.
Thank you. And we have one last final question. You mentioned the importance of involving girls and women in health preparedness planning. And what do you see are the key enablers to this?
Well, what we are seeing from research and looking at policies and programs is planning focuses on men more than on women. And planning needs to recognize and engage women early on, because women have the responsibility of ensuring that the family is secure, that the children are secure, that the older members of the family are secure. So women can say to policymakers and planners, both at the municipal and at national and subnational levels, these are the needs of the family. These are the things that we need to have in order for us to be safe. Women in transition economies, women in migration, forced migration scenarios, bear the unequal burden of caring for children and everyone else. So they can give us insights into what are the needs of the family in a crisis situation. So women must be part of the early part of the equation, and not just being provided solutions.